Now, sometimes you will find that some low socioeconomic status children, neglected children, or children coming from distant rural areas, they will not be operated even till about 2 or 3 years. In such complex unoperated patients who present late around 2 to 3 years or afterwards, there will be significant speech problems. So what you will do is you will use specialized devices called as contoured speech bulb. They will be attached to the posterior part of maxilla so that the nasopharynx gets occluded, and this will allow some degree of intelligible speech to develop in the patient. And in case you find that the maxillary teeth are missing or deformed, then prosthetic maxillary teeth can easily be used by the pedodontist in the patient. Post-operatively, you should ensure that gentle nasopharyngeal suction is given. You should make sure that proper respiratory exercises, turning over in the bed, that is ensured so there is no atelectasis or pneumonia in the child. The suture line should be clear. Aseptic precautions should be followed and should be tension free. And because these are young kids, they will be, if you leave them, they will be poking post-operatively. So restrain their arms with elbow cuffs and put the patient on liquid or semi-solid diet for about 3 weeks. And you should use special bottles once you start feeding the child. And keep the toys, foreign bodies away. And parental role is very important, that the child does not touch and does not induce infection or does not damage the sutures, because these will be young kids and there will be a tendency for them to poke into the post-operative area in the post-operative patient. Now, what are the sequelae which can occur with cleft lip and cleft palate? There can be recurrent otitis media and hearing loss with cleft palate. Maxillary teeth can be absent or malocclusion. I told you that you can put a prosthesis for this. There can be speech abnormalities, particularly hypernasal speech can be seen in these patients. Post-operatively, there can be a defect called as velopharyngeal dysfunction which can develop. If the muscles of soft palate and nasopharyngeal do not seal off the oropharynx, then velopharyngeal dysfunction will be produced. There may be difficulty to correctly pronounce the words like P, B, D, T, H and Y. Plus, these patients who are having velopharyngeal dysfunction will be unable to speak cats, boats, sisters in a proper way. The intelligible speech will not be possible for certain words. Like, I'll give you an example. My name is Sandeep Sharma. They will not be able to speak the word Sharma properly. So they will not say Sandeep Sharma, they will say Saneep Arma. You understand? This type of speech defect will be suggestive of velopharyngeal dysfunction in the patient. Velopharyngeal dysfunction can be shown radiologically. The head should be clearly positioned to obtain a true lateral view of the X-ray, and one film is obtained at rest, another film is obtained while the child is using the word boom, boom, boom during that time. And the soft palate contacts the posterior pharyngeal wall in normal patients, but in velopharyngeal dysfunction, this contact will be lacking in the patient. How do you treat velopharyngeal insufficiency? Speech therapy can be done and surgery can be done. The type of surgery include either retropositioning of the palate or proper pharyngoplasty can be performed. In other words, you will take the help of surgeons in them. This is something that is beyond our ambit of management, right? Theoretically, you can remember this.